All right, well, we're just going to wait a few minute or so and let everybody join, and we'll get started here shortly with our latest vet chat on colic. Well, all right, we'll go ahead and get started. Some other people are joining, but my name's Jamie Hayden. I'm the president of the Grayson Jockey Club Research Foundation. And joining me today for a vet chat on colic are, as you can see from the University of North Carolina State, Dr. Anthony Blikslager and Dr. Amanda Ziegler. Both Dr. Blikslager and Ziegler have ties to Grayson, past and we hope future ties with us. Dr. Blikslager is not only a funded researcher, but also served on our research advisory committee, which helps us select all of our research projects. And Dr. Ziegler was our Elaine and Bertram Klein Development Award winner in 2016, I believe that was. So we've funded both of these researchers. They know what Grayson is and what Grayson does for the equine community. And we know what they do for our horses, specifically in the disease of colic and the treatment of colic. So without further ado, I'll disappear and clear my camera off and turn it over to Drs. Blikslager and Ziegler. And I'd just like to say, before we get started, thank you guys for taking time out of your day today. I know you have students back on campus. You're dealing with remote learning, with researchers in and out, students in and out. So this is very nice of you all to devote some time to doing this webinar for us. So thanks not only what you do now, but what you've always done for our horses.
Thank you so much for having us.
Well, thank you.
Thanks, Jamie. We really appreciate the opportunity to present through the Grayson Jockey Club Research Foundation. It's a big pleasure to be here. And it's a little bit the unpleasant subject of colic, which not a lot of horse owners particularly enjoy, but we're going to try to show you some of the ways that we treat that you'll be familiar with, and maybe some newer things that you haven't had a chance to really think about so much. So we're going to talk about advances in recognition and treatment of pain in horses with colic. And the first thing I wanted to do was just show you something that you already know a lot about, which is what it looks like. And so this is a series of video clips that was taken in the veterinary teaching hospital at NC State, showing you a series of maneuvers that horses go through when they're having abdominal pain. And this is going from the least noticeable, that being pawing, to flank watching, to now restlessness, to some of the severer signs. And in general, the more severe the clinical signs are, the more severe the condition is. But I'm going to show you at the end what, by way of kind of credits, what each of these horses actually had. And please also realize that we are actively treating these horses. That means either an analgesic or a pain medication just went into the horse, or somebody's running to go get one. So it does actually say at the end of the video, treatment was not withheld, just so we could get these clips. You could tell now this horse here is more violently pawing, so it's hard to, it's just not intermittent like that one you saw in the beginning, but it's just continuous. They generally don't really know where within the whole belly the pain's coming from. They are kicking at it, pawing, try to distract themselves. It's this global sense of a big time bellyache. They don't necessarily know which side it's on or which part of the belly it's coming from. They just know that the whole belly aches. And what I usually do is sort of classify it. So when you're talking to the veterinarian, those earlier ones where they're just pawing intermittently would be mild colic. The ones where they start going down or start staying down is at least moderate or in the mid-level of severity. And then, sorry about the fuzziness of this one, but when they start rolling like this and rolling for real, like they're in pain, not just because you let them out of the field, these are typically the most severe ones. They're also the most dangerous to kind of get in with, to try to treat them and control their clinical signs. And so this poor horse has actually just been treated because I was there when this video was shot. We're up on the wall because if you go in with this weanling, it gets a little bit dangerous to handle. So here come the diagnoses, and I'm going to freeze this. And what I mostly want to point out here is that it is very difficult to tell what they have by the way that they behave. So that initial horse where it's just curling its lip up, had its large colon is impacted, which is one of the more common causes of colic. The ones that were looking around at one flank or the other, they were kind of looking at both flanks somewhat evenly. The one had a displaced colon on the right side, the other, that nephrosplenic entrapment, that's getting stuck between the kidney and the spleen on the left-hand side. There are some really strange ones that we run into. So the horse that was just plain restless actually had a peritonitis, which is just diffuse inflammation of the whole belly. Another oddball one horse that was pawing pretty extensively had an intestinal tumor. Another one that was more painful than the previous one had nephrosplenic entrapment. The one that was kicking at the abdomen had gastric ulcers, and ordinarily I wouldn't think gastric ulcers are going to show that quite a severity of pain, but it shows that they can. Another nephrosplenic entrapment, now the horse is lying down, different horse, same condition, different level of severity because it's lying down. The one that was distended had a small colon impaction, so that's all the way out toward the hind end. And then the last one that you saw, the weanling that I mentioned that's turning upside down, had actually gone to an elective surgery that we had done on its legs and came out of the surgery with a twisted small intestine, which was really a strange thing, really very painful and very difficult to control the pain on. So generally speaking, when we think about recognizing colic as a source of pain in horses, those signs that I just showed you are what we all as horse owners or managers or veterinarians think of. So this horse on the left here is kicking at his abdomen is a pretty classic sign of colic. But if you look at that horse on the right-hand side, that horse has got a hernia belt on, so it's had colic surgery already. It's got fluids hanging there, so you can already tell it's in essentially in intensive care. But if you just look at that horse standing there in the back of the stall, and if I were to ask you, you think that horse is painful, you might hesitate a little bit on what to say about that. And I certainly would have hesitated over the last sort of 30 years of practice, what I would have said. I might have just looked at the horse standing still and moved on. But we now are beginning to understand that a horse that's just standing still like that with his head a little bit low, ears back, trying not to be noticed toward the back of the stall is actually a horse that's showing behavioral signs of pain. And this kind of brings veterinarians full circle back to the horse owner in trying to understand what it is that you all are trying to tell us, which is this horse doesn't usually do this. This is not how it usually stands in the stall. There's something wrong. And honestly, as veterinarians, we have to do a better job of listening. So I don't want you to take this whole table in all at once because I'm going to show you a simplified version of it. The top line of it we went through is gross signs of pain, meaning very readily apparent, and that was the video clip. But then we're going to talk a little bit more about head position, ear position, where they locate within a stall, or it could be a field, whether they spontaneously move or not, respond to other horses, and so on. It's a whole series of assessments of their behavior that we've gone through a validated scoring system and can actually come up with a number. And out of all the numbers on that table, we're looking for about a total score of above 5 to 7 before actually gonna really recognize that as behavioral signs of pain that we're gonna actually go in and treat for to reduce those signs of pain. So if I take the simplified version of this table and kind of link it back to that photograph of the horse that I showed you standing in the back of the stall, it's not showing signs of gross pain, but that horse's head position, which is really important, is only at the withers, potentially even slightly below. Ear position was slightly back, So now I've got a score of at least 4. Location was toward the back of the stall, facing the side of the stall. So that's going to get a 2 or a 3. So I'm up above a score where we know behaviorally that horse is now what it's actually trying to do is sort of go into survival mode and not to use a pun, but just to gut it out. And that's actually a horse that needs to be medicated to try to control signs of pain. And these are things that you will have noticed as the earliest signs of a horse with colic on your farm. So it could be, again, as illustrated here in this drawing here, that horse on the right-hand side there may just be standing in the stall, potentially not interested in food. It could be standing in the middle of a field, not grazing, not really interacting with other horses across the fence or within the same field as that horse. And you recognize that that's just not how that horse ordinarily behaves. Again, this horse has got the, so the head is essentially below the withers here. The ears are back, just standing still. So this horse on our scoring system is going to get somewhere around a 5 or a 6. And this would be cause for calling out the veterinarian and for discussing what sort of medical treatment. If you just give them a score over the phone because everybody's smart about these things and catches onto it pretty quickly, they're going to be a little bit shocked and won't quite know what to do with it. So you're going to have to say, look, I'm picking up these behavioral signs of pain and I'm really worried about this horse. What should we do next? I'm going to take this even a step further, and on this diagram here, researchers have started realizing that when horses are in pain, their facial expression changes. So, and it changes in 2 important places. One is the muscles above the eye will tent. So if you can see the arrow right there, there's this kind of tenting above the eye, so they essentially look anxious. And then the other thing that happens is that the muscles alongside of the face will also tense up. So if you see the lighter line on the horse in panel A versus this heavier line here, that's just the muscles on the muzzle are tightening up. So you just look at that horse and you feel like they look anxious to me. And in this case, they're anxious because they're painful. So again, that's something that we want to call the vet about and tell them what you're seeing and see what you as a team want to do about it. So these are the pain management options that we're going to talk about briefly today. And this is a simplified system of how I would work up a colic patient. So for those horses that have just behavioral signs of pain, or else it's just mild or moderate, so maybe they're pouring intermittently, or else they're beginning to lie down, but they'll get up pretty easily. We'll do a brief physical exam, most importantly to get the heart rate. So by feeling a pulse around the head or by listening for one with a stethoscope. I'd like to be able to look at gum color and just get an impression of how the horse is doing, and then really want to treat them as early as possible. So as soon as I've kind of assessed them at the level of the head and maybe listened to their heart to confirm what the heart rate is, I'm already ready to treat that horse. And this is where this can become a little bit difficult because you'll be seeing these things on the farm before the veterinarian gets there. So for me as a veterinarian getting there, the medications that I would choose are, one is a sedative, the generic name is xylazine, the most common trade name is Rompin. The other drug that we'll sometimes use in combination with it, usually not alone, but in combination, is Torbugesic. And the reason for picking those 2 drugs there is that they only last about 40 minutes. So they're kind of potent drugs. They're a little bit less likely to be on the shelf in the tack room, but they're good painkillers and they will wear off. And the importance of that for me is that in the time it's going to take me then to do the rest of the exam. So in the green box now, I've got response to those, let's just say. I'm going to perform the remainder of the exam, and then I'm going to be ready to put a longer term pain medication on board, so most typically Banamine. But that first line treatment, that gives me an opportunity to see whether or not that horse will have a recurrent episode of pain or not. And the horses that you really want to watch out for overall, regardless of how you start treating them, are the ones that have recurrent pain. That puts them into a higher risk category for needing something more than what you can do in the field, and more likelihood of thinking about calling out the veterinarian for sure, but shipping the horse potentially for some intensive therapy, usually medical, sometimes surgical. The most common drug then that I would imagine you all are familiar with will be Banamine. That's a strong painkiller also. It's in the non-steroidal anti-inflammatory drug class, like a little bit like IV ibuprofen for us. It lasts about 6 to 8, maybe as much as 12 hours. So the downside there is if you use that, it's a little bit difficult to tell when the pain, if it's going to come back, how fast it's going to come back. The way to organize these things, I think, with a veterinarian is have a conversation about how you're going to manage your cases ahead of time, just when they're on the farm doing other things. And then my preference is for owners to give me a call and say, hey, this is what I'm seeing. This is what I've got. I know it's going to take you 40 minutes to get there. Or in my case, you might be shipping here. And we'll discuss what you have there on the farm and what you can safely give. And that would give us a sort of a time point. Like, let's just say you give that right now, it's 2:15. That Banamine shouldn't wear off for the next 8 hours or so up until the evening. Please call me back as soon as you notice anything. And I'd even be willing to come out and just take a look and see how the horse is doing. That lower red box there is for the horses that don't respond to the initial treatment. For me then with Rompin and Torbugesic, I'm going to make the exam even briefer. The one thing I'd like to be able to get off the horse is a heart rate, so a pulse, just because those drugs, or one of them that I just mentioned there, Rompin, will lower the heart rate. And heart rate has been shown to be one of the most predictive measures of whether or not they ultimately need intensive care or potentially surgery. So top end of heart rate should be 48 beats per minute. Most field colics won't get above that range. The ones that are heading into more dangerous territory are the ones where it's above 48. And it's good to know that before you treat. Some of those horses, on the other hand, in the red box there, are so severely painful that you just have to get something into them, even if it's intramuscular. The drug we tend to reach for as it gets really severe like that, when they're down and thrashing, is Dormosedan, which is like a relative of Rompin. It's the same drug class, it's just quite a bit more potent. That'll last 2 to 4 hours, and it's the strongest thing that most veterinarians will have on the truck. And then beyond that, people call and they say, we just can't control the pain. We've tried actually all of these things. What can we do? And the only thing we can do at that point is get them shipped as soon as possible. And honestly, sometimes they come in there that painful, we'll anesthetize them pretty quickly in preparation for surgery. So just to go back over those sedatives that I mentioned, which are called alpha-2 agonists, Rompin and Dormosedan. The Rompin is best choice for a potent, short-acting analgesic. It's a sedative. It does make them a little light on the hind end, so sometimes people will say, you know, you're more likely to get kicked, and that could be true. But nonetheless, it's good for sedating them for some of the other parts of the procedure that's going to be done, including passing a stomach tube. And it will reduce the heart rate. So it's one of its physiologic effects is to do that. And then the Dormosedan, we just keep that on hand for the most severe cases. It's not something we really like for owners just to give, particularly early on, because for one thing, we'd run out of options, but for another, it's actually going to cover up quite a bit that's happening under the surface that needs to be paid attention to. There is one other option I just will put on that slide where we're really in a bind and we're in a hospital scenario is to actually give it as an intravenous infusion continuously. The Butorphanol or Torbugesic it's an opiate, so it's in the same kind of class as human drugs like codeine. The trouble with opiate drugs is they make horses a little bit excitable. It's the reason that we don't use drugs like morphine typically all by themselves. So if you give a full dose of this by itself, it'll make the horse look a little bit excitable and jittery. So we'll use a lower dose, around about half a cc with the sedative to get a little bit more pain control. But again, it's only going to last 40 minutes or so by itself, given intravenously. This is a drug that we have done a fair bit with in the hospital as a continuous IV infusion. And so I think most people are aware of how human patients are treated, particularly after having a knee replacement or something like that in a hospital and they're on a pump. We actually can use these pumps on horses to give pain medications. And one of the studies I wanted to go through is where we actually looked at that. And it's going to begin to tie together a couple of the things that I've talked about already. So we did a study on butorphanol as a controlled rate infusion, or meaning in a pump, in horses after colic surgery. So we're already treating them with Banamine, IV fluids, antibiotics, everything else. But we did this as a blinded, randomized clinical trial where some horses got the Torbugesic and the others didn't, which seems a little unfair, but this is how we figure out what to use when we just don't know how effective it is. And that's a listing in that table of what the horses had that went on to this treatment. So they all went to surgery. You can see there's a treatment group and a control or untreated with at least Torbugesic group. Large colon impaction, large colon strangulation is a twisted large intestine. And then small intestinal impaction, which is mostly ileal impaction for us in the Southeast, and then twisted small intestine. So pretty evenly divided between those. And when we look at this next slide here, I just want you to look at the total black bar there. That's the behavioral pain score coming right out of surgery within the first 24 hours. And what it shows is that the horses that were on butorphanol had a lower pain score in the black bar than the untreated horses in the kind of hatched gray bar. And that was consistent amongst the different ways that we have to assess that pain score. So it's just broken down into the full table I showed you, or part of the table, so that black bar to the rightmost over here is just part of that one where I showed you about head position and so on, where you can see these horses here that get the butorphanol are significantly less painful than the ones beside them. One of the reasons that this is not always done, now that we know that it's a good pain control method above and beyond the Banamine that they're already on, we worry about passage of manure. And so one thing that opiates can do is cause constipation, which is not really what you would want in a colic patient. And so we looked at that, and sure enough, there is a delay in the transit time to the passage of manure in those post-op colic patients. So all the way out to about 48 hours in some of them, up here at the top of this bar, and not within the first 24 hours in the ones that are untreated. So this is something we worry about. None of these horses got into a major bind because of it. So overall, we like to use this to decrease their pain, but we have to be aware of how long we're doing it for and whether or not there's any constipation going on. And at this point, I'm going to turn it over to Dr. Ziegler to talk to you about the non-steroidal anti-inflammatory drugs.
Yes, hi. So I'm Dr. Amanda Ziegler. This is Tinka. I hope you don't mind her presence. It's not really optional. So she'll be here with us the whole time. But as Dr. Blikslager was talking about the side effects we have to worry about with some of the drugs we give for pain management and colic, I have spent some time, I'm a research veterinarian. I've spent some time studying the effects of non-steroidal anti-inflammatory drugs on equine patients, and considering the ways that they work is really important when we're making these clinical decisions on how to treat pain. So just as an introduction to the way these NSAIDs work, normally under normal conditions, our bodies can create these signaling molecules called prostanoids or prostaglandins. They're derived from phospholipids, or the structure of the actual cell membranes in our tissues, and they're converted from the membrane phospholipids into a substance called arachidonic acid, which is then converted into these signaling molecules called prostanoids. And those prostanoids are formed by several different types of enzymes, but two that are really important are the COX cyclooxygenase enzymes. And the two most important that I'm going to talk about today are the COX-1 and COX-2 isoforms of that enzyme. COX-1 under normal conditions is always active, generating a small amount of prostanoids that are important for normal cell function. So those little small amounts of prostaglandins are secreted at a normal rate just to promote normal function. And on the next slide, I'll talk about those normal functions. However, COX-2, you can go back, Anthony. COX-2 is it's what's called an inducible enzyme of cyclooxygenase, which under disease states like in colic, where there's injury involved, the COX-2 enzyme is increased and it causes a huge amount of prostaglandin synthesis. So COX-2 will generate lots and lots of prostaglandins. And this is what is responsible for inducing pain pathways and inflammation in tissues. And so this is what is causing those pain symptoms that we see in horses that are colicking. And importantly, we are able to control this process and reduce it by the use of the NSAID drugs. They block the action of COX enzymes. So we're able to really reduce that pain and inflammation by treating with the NSAID drugs. NSAIDs that you guys are familiar with are probably most commonly Banamine, which is Flunixin, Meglumine, and others that are available might be Bute, which is also similar to Banamine, and then Firocoxib or Equiox, and then Meloxicam, which is usually used more commonly in other countries, but is available. I think they actually use it a lot for cats, more so than horses in this country. So Anthony, if you could advance the slide. This is a diagram that we recently published to illustrate the difference in those targets of these COX inhibitors, these NSAID drugs. So as you can see over there with the kidney and the intestinal loop there that are highlighted, COX-1 enzymes are important for driving normal kidney function and normal intestinal function. So particularly in the kidney and in the intestine, these low levels of prostaglandins help to regulate normal kidney urine production. And then in the intestine, it's really important for several functions, but mainly barrier function. So in the intestine, we have a single epithelial cell thick layer of intestinal lining, which is responsible for absorbing all the nutrients that you and your horse eat, but also is really important for blocking out all of the harmful substances that are in the intestine, all those bacteria and their bacterial products from getting into your bloodstream. And so COX-1 activity produces just a little bit of prostaglandins in the intestine to help promote that barrier function. And that's really important for normal physiology, but also for repairing that in the case of an injury. So if you have a disruption in that barrier function because of an injury related to colic, then it's really important that that COX enzyme is there to help accelerate that healing process. And then over there at the where we have the purple gums and pawing going on, we're showing signs of what's called clinical endotoxemia, which is a big word for sepsis, which is maybe something you've heard, which is where those are the signs of that bacterial product and bacteria getting into the bloodstream and causing widespread inflammation in the body. When we give drugs like NSAIDs, we can block the effects of COX-2 producing all of those prostaglandins in that disease inflammation state, which will then effectively reduce signs of this endotoxemia syndrome, and it will greatly reduce pain. And we can do that with any of the NSAIDs. But what's interesting is that some of these drugs are more selective or less selective for the different types of COX enzymes. And so if you'll look at the non-selective and selective COX enzymes up in the top left corner include all of the NSAIDs, Banamine, Equiox, and Metacam will block that COX-2 activity that's causing pain and inflammation. But if on the other side, you'll see that Banamine is considered a non-selective non-steroidal anti-inflammatory, which means it will also block COX-1 activity, which can be a problem if you're talking about a horse that maybe has some systemic problems already. If they're very sick, if their kidney function is already in question, then you might need to reconsider using a non-selective drug like Banamine. And then the same goes for the intestine. If you have a colic patient whose intestine has been damaged, then we might be hindering their ability to repair by blocking that COX-1 enzyme with a non-selective drug like Banamine. And so that's something that we've been doing a lot of work to try to understand better. Did you want to take this one, Anthony, or do you want me to?
These are the COX-2 inhibitors that are available for horses. So just to reiterate, these more selective drugs, they've become quite popular with the advent of Equiox, or it was actually given as in the canine form Firocoxib before as a small 57 milligram tablet a lot of people are using for arthritis in horses. And in many ways, owners were actually catching on to the fact that that was a safer drug on the stomach, at least, for a horse that was lame. But we've also been interested in these drugs to figure out, well, are they useful for colic, and potentially are they a little bit safer because they don't have side effects on either the kidney or the intestine, as Dr. Ziegler explained. So with Metacam, that originally was available in Europe, Canada, Mexico, actually everywhere except the US. The small animal formulation is available in this country, and BI never actually has marketed the large animal formulation here. But Equiox is marketed, as you know, in this country and also in Europe. And that's just a picture of the packaging there down on the lower right. So importantly with Equiox, and this is the paste form here, this is the IV form, so it does have this intravenous form. There's a couple of things that are peculiar about Equiox. So for example, you can give it straight IV. If you've got the solution, you have to be careful not to put it into an extension set on a catheter, because it just turns the extension set white. Not through any particular negative interaction, but it's a little bit alarming when you see it. But it's certainly very safe for the horse if you give it directly intravenously. And when we use it in the clinic, or when Amanda used it, we would put a hub on the catheter immediately adjacent to the catheter so it would go straight in. The other way to do it is to pull back blood into the syringe to let it mix and then push it in. Was not something that the company that manufactures it had anticipated, I don't think. So this was an experimental study where we actually reversibly create intestinal ischemia. So this is jejunum here. This is a clamp across here, just as if it were twisted, but we're doing it artificially here. And this is a blood vessel that's clamped off. And then what we're going to do is let these clamps off and let that reperfuse. So this is a little bit more like a colic patient that we can then treat and understand a little bit better what's happening on the inside of the horse, in the intestine, but then also what the outside of the horse looks like, as in how painful is this horse. And fortunately, they were not particularly painful, but there were some behavioral differences that I'll show you. So if you clamp off this blood supply here for a couple of hours, and so you can imagine that's a pretty long-term twist to have, but many of the horses that we see, unfortunately, twisted for even longer than that. But after 2 hours, if you look at the internal lining on histology of this intestine here, this is normal in panel A. It's got this single layer of what's called epithelial cells that line the gut. So this is where the feed would be, and the bacteria out here. These are these finger-like projections that help absorb nutrients and salts and so forth. When you cut off the blood supply, this this structure here starts retracting to make the size of the gap smaller. And then the cells that are on the lining here are pretty sensitive to a lack of blood flow or a lack of oxygen. So they just start falling off into the central part of the gut, into where the food is. And that's when you start seeing horses that actually look sick, as in like the purple gum color that Dr. Ziegler showed, because they have this area here is now exposed. And so bacteria and their toxins can get in here, and horses are pretty sensitive to that. And it starts creating problems with their circulation. It'll make their heart rate go up and the gum color turn abnormal. But then pretty rapidly, this will heal itself. So the gut is a pretty amazing organ. If you can untwist it pretty quickly, it'll sort itself out. And that's really one of the major goals of managing colic, is to get to it, particularly the severe ones, as fast as possible. So this is within about 18 hours or so. This is, you can tell this is contracted down even more or shriveled up that much more, but it's resurfaced itself. So that's a lot like a skin wound that you might imagine, but it's happening super fast, like within 12 to 18 hours, not within several days. And that's because it's just so important to get that barrier reformed. This is a biopsy from one of these horses here where the clamps are off. It's allowed to heal and the horse is getting better again. We're just looking at this biopsy here. If, however, you look at these repairing cells right here, there's one specific thing that I want to point out. So some of the horses in this trial are on Banamine at the regular dose we'd use in the clinic, so roughly 10 cc's twice a day. And although the Banamine didn't affect this whole healing process right here, what happens is if you look at the individual cells, so this is one cell, but this is called a brush border up here, adjacent to another cell. This is the lining of the gut here, but it's in super high magnification. You can tell there's a gap between these cells right here that hasn't quite zipped up yet. And because there's a gap there, it's kind of filling with fluid below it. And we know that we can get bacterial toxins across this gap and in here. So paradoxically, what's happening is the Banamine, this is associated with its effects on the gut, is slowing down that particular part of the repair, that final zipping up step. It's not something you would worry about on a regular field colic. It is something you'd start worrying about on a horse that has an intestinal twist and you're trying to get it to repair itself. This is what the horses looked like that didn't have any Banamine. They had other forms of pain control, but this closes up tighter. And this initial observation here, it wasn't particularly popular with veterinarians because we felt like we were doing the right thing by using Banamine. It's essentially a side effect that we have to be aware of. So in the trials that we ran with horses like this is a pain score panel on the left. This is exactly using that same pain score system I showed before. In this case, though, there's 3 groups of 6 horses that are treated with either just saline as the placebo, S for saline, just salt solution. Flunixin is for Banamine right here, the F. And this is Meloxicam. So now this is Medicam. This is us trying to look at drugs coming onto the market that are a bit more selective. And what you can tell here, pre-operatively, there's not really any pain to speak of that we can tell off this behavioral pain score, but there is after the surgery, after they've had this ischemic event and then the clamps have come back off. These horses that are on saline, they're also getting Torbugesic, but they're more painful than these that are on Banamine and Medicam. So the good thing here was that what we're looking for here is kind of equivalency of pain control between these 2 drugs, because we're going to try to go after an advantage of a more selective drug. And then over time, you can just see this pain coming down here. Even in these saline controlled ones, it's coming down within this 16 to 18 hour time period, and still not really observable in these other 2 groups. The difference then between these 2 groups here, the Banamine treated ones and the Medicam treated ones, is over here. So if you take a piece of that intestine that's repairing after 18 hours and look at it in the lab, the horses that receive Banamine intravenously twice a day are in the intestine that's ischemic injured, so it's had a lack of blood flow and it's injured. This yellow bar indicates it's leaking more toward bacterial endotoxin than the other groups. And the reason it's leaking is because of that previous slide that I showed where there's a gap in that repairing epithelium. So this is not something we'd really want to see. It's actually partly why we treat horses with Banamine, to counter the effects of the endotoxin. And if you were to ask me, well, is this going to make or break this case? We don't really know the answer to that, but it's, as Amanda will show you, it's not really something that we want to see. And we feel like by using these more selective drugs, we can potentially get rid of that part of the picture that we would see after surgery. Very, very similar if we use Equiox or intravenous Firocoxib. Same sort of picture with the pain scores. You'll notice it's not quite right out here, 8 hours. This Equiox is not quite as effective as the Banamine. Partly the reason for that, we believe, is that when we started using this drug, they didn't know that you have to give a high dose to start with and then back it off. So these guys are on a low dose to start with. So as you'll see, when we get this into an actual clinical trial, it's a bit more effective. But the part that does look kind of similar is, again, on these ones that get the Banamine. So it's a different group of horses now. They're at 18 hours at least leaking, their gut is leaking toward the endotoxin. So it's going to make them a little bit sicker, even though it's hard to see. And then we don't see that effect with the Equiox. So I guess the way you would look at that is, you want pain control, you just don't want the GI side effects. And I don't want to make anybody paranoid about these drugs. We're talking about horses that have severe intestinal injury. Those are the ones we think you have to be careful with. So I'm going to turn it back over to Dr. Ziegler for this Grayson Jockey Club Foundation funded trial.
Yeah, so back when I joined the Comparative Gastroenterology Lab a few years ago, we were just starting this trial. And so together with Michigan State and University of Pennsylvania, our university, NC State, enrolled horses in this randomized controlled trial in order to compare the effects of Flunixin and Firocoxib, Banamine and Equiox in horses that had been recovered from these kinds of severe strangulation injuries in the surgically in our referral hospitals, and see if we could find detectable differences in the way that these horses did, and try to understand whether these differences that we see in the lab are really relevant and important for horses that are being treated in real life. And this study was funded by the Grayson Jockey Club Research Foundation. So it was really important work that we were able to do with their support. All right, thanks, Anthony. So what we found was we had taken horses that we had recruited horses, I should say, that had been admitted to the hospitals at those 3 universities that fit the description of a horse that had a severe intestinal lesion that would require surgical correction, a strangulating type intestinal injury. And we asked those clients if they wouldn't mind enrolling in this study, where we would choose, randomly assign them to receive either Flunixin or Firocoxib, Banamine or Equiox, in order to see the differences in their pain control and ability to recover. Going into this, we fully expected that Firocoxib should be able to fully control pain in the same way as Flunixin, Meglumine, Banamine, based on the preclinical trials that we had done, and also using that higher initial dose with the Firocoxib. So we were confident that these horses wouldn't be overly painful. And fortunately, since we got a good number of recruited horses, we were able to confirm this. So if you look at that first pain score graph, it's showing you the pain scores in those horses using a 36-point scale that we use at NC State University. And if you look at Flunixin, which is blue, versus Firocoxib, which is the red color, you can see initially there is good pain control, and then throughout the entire postoperative period after surgical correction of these severe lesions, we were able to completely similarly control the pain to an adequate level with both drugs. And actually, at 96 hours, both drugs had significant reduction in their pain score when you compared it to their original level of pain. So that was a really good sign that this Firocoxib Equiox drug does a similarly good job in the actual clinic at controlling pain as does Banamine. Another marker for pain that we measure frequently, as Dr. Blikslager mentioned early on, is the heart rate. And so if we just take heart rates and compare them across groups, we can see that there's overall a decrease in the heart rate over time in the 48 hours after surgery. In both groups, it's very similar. So this also shows that we're having good amount of pain control from both of those drugs. And so this is where it gets into that complicated COX-1 versus COX-2 activity, and trying to determine whether treating with the Equiox, the Firocoxib, which is supposed to be a COX-2 selective drug, will allow COX-1 to continue its normal baseline activity to promote things like renal and intestinal barrier function and intestinal barrier repair in these horses that have had severe intestinal injuries. So one of the markers that we look at, so we look at two markers to measure the COX activity, COX enzyme activity in horses. Thromboxane B2, which is that chart there, tells us how much the COX-1 enzyme is being suppressed, and then prostaglandin E2 will tell us how much that COX-2, or the pro-inflammatory pain-causing COX enzyme, is active. And what we found is across both groups in the prostaglandin graph, what you see is that both groups have similar levels of suppression of prostaglandins. So there's no differences between the Firocoxib drug and the Flunixin drug, the Banamine and the Equiox, throughout the 2 days, both preoperatively and throughout 2 days postoperatively. When you look at the thromboxane B2 graph, which is that marker of that COX-1 enzyme, which is important for normal baseline functions, you can see that since both horses, so both groups had gotten some Flunixin Meglumine early on, and this is because a lot of people will give Banamine in the field. It's just very common, as Anthony talked about, to use that in the early stages of working up a colic patient at the barn. So we made sure that all these horses were the same, and they all had an early dose of Flunixin Banamine before surgery. But then when you look over time, as that Banamine wears off and they're only on the Firocoxib drug, the Equiox, you can see that big difference there between the thromboxane B2 levels between Flunixin and Firocoxib, showing that the Equiox is allowing that COX enzyme activity, COX-1 enzyme activity to increase, which theoretically should allow for more baseline function of low levels of prostaglandins to promote barrier function in the intestine of these horses that had those injuries. So then, as a measure for what we were seeing with that purple gums and the systemic pain signs termed endotoxemia or sepsis, a lot of times we'll try to measure LPS, which is lipopolysaccharide. It's a component of the bacterial cell wall that when your body sees that bacterial product, that bacterial component, it reacts dramatically with a huge inflammatory response in order to try to attack bacteria that might be invading your body. LPS, though, tends to be released in bursts when you have it in your bloodstream. So you can have what's called a shower of LPS bacterial toxins into your bloodstream or into your horse's bloodstream during an injury like this, but they can be very quick. And like, if you take a sample at a moment where it's not happening, you might not detect it, but that doesn't mean that it's not going on. And then every now and then you'll get a burst of LPS and see it in the serum, in the blood. And that can be a little bit difficult to measure as a marker of that bacterial toxin being there. What we have found, though, is that there is a protein called soluble CD14, which is a protein that is secreted by a type of immune cell called a macrophage. When the macrophage sees that bacterial LPS, it releases SCD14 and it remains active and continues to secrete that SCD14 even after that LPS shower is gone. And so this is all just to tell you that the soluble SCD14 is a more stable marker of endotoxemia or sepsis in equine patients. So for this study, we decided to measure the soluble SCD14 in the blood to see if there was any differences in the leakage of these bacteria products and the inflammation that results from that in these patients, since our hypothesis was that that Flunixin is going to suppress those COX-1 baseline activities, which would slow down or perhaps impair that barrier repair in the intestine. And so what we found was when you look at, we'll start at the bottom with the SCD14 since I just talked about that. When you look at the levels of SCD14 in these horses, throughout the first 24 hours, there is no difference in the amount of horses that have elevated levels of SCD14. But when you look at 48 hours after surgery, which is that time point at which we know that we saw the COX-1 enzyme working better in those Firocoxib treated horses, we see fewer horses in that selective drug Equiox group. So in theory, this is showing us that there's more horses that are not endotoxic. Well, I'll phrase it this way so it's a little more direct. There are more horses that are showing that endotoxin marker SCD14 at elevated levels in the Flunixin, the Banamine group, in that 48-hour time point, that 2-day time point after surgery, versus the Equiox group. And then as a measure of just whole systemic inflammation, TNF alpha is a molecule that is secreted to induce inflammatory responses in the entire body. Basically, any cell can create and react to TNF alpha, tumor necrosis factor alpha. And it's just a good marker for overall inflammation. And what we're seeing here is no difference between the groups. So the horses don't seem to have a major difference in this inflammatory marker. And so all this tells us is that it's pretty complex signaling, and we probably have a lot more work to do to really tease out whether or not these are going to be clinically relevant or important for every horse, whether or not we need to use selective versus non-selective drugs. We have a lot more research that we can be doing.
Yeah, the only other drug we wanted to mention is Buscopan, which is also available in Europe in combination with a non-steroidal anti-inflammatory called Dipyrone, but in this country it's available just as this single compound with this very long name right here, butylscopolamine bromide. You probably have heard about this and encountered it and wondered what its use is, and honestly most veterinarians are sort of wondering the same thing. It is antispasmodic or anti-intestinal contraction activity. So one sort of sideline usage of it is to facilitate rectal palpation, just to relax the horse a bit more while doing a palpation. But the true use of it for colic is for horses that have what would be called spasmodic colic. And these are horses that show colicky signs and where the veterinarian will come out and listen to the gut sounds. And sometimes you can even just hear them without a stethoscope and hear all these increased gut sounds. That's its single greatest use. When you give it, it actually elevates the heart rate, as opposed to the drugs we talked about before that lower it. So it's advised to take the pulse again early on, to give it, and then give yourself about 25, 30 minutes or so before reassessing the heart rate. And so this is just literally from the manufacturer here, but it relaxes these intestinal spasms, relieves the pain caused by that spasm, those increased gut sounds, or like crampiness within the gut. Some of these are gas colics also, and simple impactions, but the most indicated ones are these spasmodic colics. And then that should relieve it within about 30 minutes or so. So just another drug that's available on the market for treatment of pain. And it can be used in combination with any of the other drugs that we mentioned. And so overall, I think what we presented here is how to have a better sense of how to recognize pain, not just including the very readily apparent signs, but also the behavioral signs of where they're just not holding their head and ears the way that they ordinarily would. We've suggested what is currently called multimodal pain control. So I mentioned using Torbugesic and Rompin, which is a use of an opiate and a sedative alpha-2 agonist. And then frequently we will use Banamine. It's certainly in the field as a non-steroidal anti-inflammatory drug, and frequently over the top of those other drugs. Anytime you can tackle pain pathways from more than one direction, it tends to really help that much more. We've talked about some of the side effects of the non-selective, non-steroidal anti-inflammatory drugs. So we mostly investigated Banamine. Perhaps it's more understandable if you think about Bute and how that's been associated with gut ulcers. Mostly what we found with Banamine is it just, although it's an effective pain medication, it slows down gut repair. So as they kind of get into that gut repair stage, it really would be advisable, we think, to try a more selective drug like Equiox. And you won't see this frequently, but we're already talking to our veterinarians about if they think it's one of these really severe cases to consider that particular drug versus the Banamine. And then some other novel approaches. So using the COX-2 selective inhibitors like Equiox to reduce pain and inflammation, overall we feel like is really beneficial. And at that point, I think we'll turn it back over to Jamie.
Yeah, thanks so much. For those of you online, if you have questions, you can use your Q&A tab at the bottom of the software. And then you can, well, I don't know, you can turn your share off, Dr. Blikslager, if you would like to as well. But I do have a few questions real quick for you while others may type some. You had weanlings, I believe you had a weanling in the beginning of your presentation, obviously older horses. What age is generally associated with colic, or is this anything that can happen to any horse?
That's a really good question. I mean, it is anything that can happen to any horse. So we do see it in foals and weanlings and older horses. I would have to say that most of the colic admissions that we get are mature or even older horses. But we are actually doing a study to compare foals with adults. And so in the relatively few foals that we tend to see, at least for colic, just to look and see how the survival compares between the two groups. And they actually do remarkably well to the point where we feel like those younger age groups are really worth taking the surgery too if they've got a severe case.
Yeah, so I think that leads us into my next question that somebody had, which was, what's the repeat nature of colic? We hear a lot about colicky horses or, describing a certain horse, but is it a colicky horse, or do they have something that makes them susceptible to having repeat colic visits?
Yeah, I think the most, it's really easiest to think of as a management disease, meaning not really that anybody's doing something incorrectly, but the first places to look for particularly recurrent colic is changes in diet, changes in exercise, or even just whether the diet or the exercise that you're already giving that horse is the right combination, meaning horses do best when you maximize the forage intake, so grass and hay, and minimize concentrate, so the pelleted feed. They do better when they're exercise routinely or just in general have a routine. So for those where there's turnout, it's really helpful. For those that are stalled, it's great to get them on a daily exercise program. The ones that probably recurrently colic are the ones where sometimes in the show horses, you're trying to push them a bit on the energy of the feed, and they get these kind of changes in their bacterial populations and they get a little gassy. periodically, and also they're under some level of stress, and also they're being shipped and stored more often. So that's kind of a combination for a repeat colic patient. There are some horses that just have something more chronic that's going to bother them over a longer period of time. So stomach ulcers are a pretty good example of that, where there is a real underlying condition that you need to figure out and get that sorted out to reduce the colic.
So much like laminitis, when we hear something else cause laminitis, colic fits under that. Well, we had this episode, now we've got colic associated with it as well. Is that right?
Yeah, that's right. I mean,
go ahead.
Those two conditions are sometimes associated. I mean, fortunately, laminitis doesn't come as a complication of colic that frequently, but one example of where they are connected is where a horse is on a relatively high carbohydrate diet, like lush grass in particular, and that will cause a change in the bacterial population in the colon, which makes them gas up a little bit and colicky. And it actually makes them a little bit endotoxic. It creates a little bit of a leak in the gut, and then they'll have these systemic effects, which can include the feet. So the feet are a little bit like a shock organ in the horse. You would hear about more lungs in people, but it's the feet that really, because they've got such a delicate blood supply, that if the blood supply is affected for the whole horse, it tends to affect the feet.
Yeah, so you were saying for stalled horses or show horses, race horses, you know, maybe a change in environment, change in diet, stress, shipping, that kind of thing. But then I think I just heard you say maybe changes in grass for those horses that are out in the field. So maybe springtime and when the grass is dying, is that right?
Yeah, it's this, you know, they get that lush green grass in the spring. We really recommend very limited turnout on the lush grass. We recommend mowing it to cut it back as much as possible. And I think everybody's probably got a pony that they can remember where, you know, they're just such effective kind of mowing machines, and you turn them out on grass like that, it really affects their feet pretty quickly. Mm-hmm. So it's the lush grass in springtime particularly. It even varies by time of day, and we'll just recommend in that instance, like most farms have got a dry lot someplace where they can turn the horses out instead of putting them on the lush pasture until they get that under control.
And then here's a great question. It said in the medicine graph earlier in the presentation, how long do you generally wait between trying another medicine for uncomfortable horse? So let's say between Banamine and then xylazine, how long do you wait?
So between Banamine and so the two are sort of independent. So if you've tried one, you can try the other, and there's no harm in doing that. It's actually, to some degree, they're going to act almost together to have a more potent effect. Mm-hmm. So if you've given Banamine and now the horse is having pain again, and you call out the veterinarian, they can still and probably will use that sedative Rompin as a more potent short-term analgesic on top of the Banamine. And then you can do it the other way around too. So the big difference between the two drugs is that Banamine at a full dosage, that's about 10 cc's, is only indicated twice a day, because otherwise you really do start seeing the side effects. Whereas with the Rompin, it's as needed is the kind of the direction on that we would use.
Huh. Another question is, you hear a lot about gut and stomach, and is this something you can hear? Some of this rumbling, or is this another sign to be listening for? Is the upset stomach? Is that?
Yeah, you can. It's actually a great idea if you just know what your own horse's baseline gut sounds sound like. So you can hear the guts normally. So you can, if you don't have a stethoscope, you can literally just press your ear right up against your horse's side if they'll let you safely. And you can hear gut sounds gurgling, just like how your own gut makes sounds sometimes. It's called Butorphanol. It's got a great name. Butorphanol. But if you know the normal amount of sound your horse's guts make, then if they are showing signs of colic and you can listen again safely, then you might be able to tell a difference whether they've decreased or increased, and that could be important information to tell your vet.
Yeah. So a different kind of horse whisperer, right? I mean,
Yes, horse listener.
yeah. So, and I get the final question, unless anybody else has one, I'm asking is, how have you seen the treatment of colic change over your career since you all began this? And I'll let you answer independently because I know your careers have been different lengths.
Yeah, for me, it's, I know it would actually go, I mean, sad to say, all the way back to the days where we didn't even have the sedatives like Rompin. So we were just very reliant on non-steroidal anti-inflammatory drugs. Actually, we would use phenylbutazone early on. And we would push it more. So back in the 70s, early 80s, you know, do a lot more repeat treatments on the farm and leave the surgery to the absolute last ditch effort. Up until now, where we're really advising that just give a medication a safe dose once, do it in consultation with the veterinarian so they know what you're doing. And if they have a repeat episode of pain, that's now a more serious category that you start considering whether, while they're relatively healthy, you actually want to send them someplace to get treatment.
So I don't see any more questions. I would just like to say thank you all so much for taking your time to do this today. It's been an excellent presentation. Someone actually sent me a note that said this should be required viewing for every horse owner. So high praise from those individuals. And we just can't thank you enough for not only the work that you're doing in research, but also the work you're doing in just treating the horses in your area and then sharing that with us, because it's been a great experience getting to know all the different veterinarians and seeing how the community of veterinarians is probably the most information sharing and reach out to their colleagues to try to learn new things. And I'm always impressed that you guys are willing to learn from each other as well. So thanks so much.
Thank you so much for inviting us.
Yeah, this has been great. And if we get any more questions, I'll follow up with you. But thanks so much. This has been a fantastic presentation.
Thank you.
Thanks, Jamie.
Thanks, everyone.
Thanks, everyone.
Bye.
Bye.